to the organizer and especially to Fernando to encourage me to present this data. I have to say that I'm not going to talk about cytokines and genes, not even about RSV, but okay. Bronchiolitis is an acute respiratory viral infection affecting infants and toddlers worldwide. To assess the severity of the patient, clinical symptoms like respiratory rate, heart rate, wheezing, respiratory muscle, and oxygen saturation are gold standard. So several different clinical scores are used to assess the severity of the patient. Here in Argentina, we use the most frequent one is the TAL score, which is modified from the original one. So infants and children born and living at high altitude have increased lung volume compared with infants from low altitude. The high altitude hypoxia affects the value of saturation in children. Oxygen saturation is one of the solid parameters to assess the need of additional oxygen in an acute respiratory severe viral infections, plus the clinical picture of the patient. But it's not clear if the normal range of value for oxygen saturation in healthy infants at high altitude area. So the specific aim of this data are evaluate oxygen saturation and respiratory rate in healthy infants and toddlers younger than 2 years of age, born and living at high altitude, and compare with infants and toddlers younger than 2 years, born and living at low altitude. This data is part of the research performed in the northwest of Argentina with collaborative with Rob Tepper from Indiana University and people from La Quiaca, which is the high altitude place. In my place is the low altitude. Okay, this is La Quiaca, which is in the border with Bolivia. My city is Tucumán in the northwest. And here is Bariloche, where we are now. So the group 1, the low altitude group, infants and toddlers 1 to 24 months of age who were born at low altitude, Tucumán, Argentina, which is the north. It's very nice, close to landscape like here. And the second group, it's the high altitude in La Quiaca, Argentina, also infants and toddlers 1 to 24 months of age who were born at 3,400 meters. Here we have llamas, doctor. So these were healthy infants in both sides. The exclusion criteria, preterm baby, and gestational age younger than 37 weeks. Low weight for gestational age, congenital cardiopulmonary disease, admitted at hospital by respiratory problem, and treatment for asthma. So we analyzed the oxygen saturation, respiratory rate, heart rate, and levels of EPO, erythropoietin. That's the demographics for the group. The 50 infants in the high altitude group and 35 in the low altitude group. No difference, that's the gender distribution, and no difference in age, weight, and length for the groups. So that's the saturations for this is part of one of the research to measure lung function. So we need to sedate the infants with chloride hydrate, keep the respiratory partner like a basal way. So this is the saturation for low altitude, the red one, and high altitude group, males and female. I split by females here, which is different, low altitude from high altitude, And also a significant difference for males versus high versus low altitude. Because we found in the main research that the lung volumes were bigger in the infants, but much bigger in boys than girls. So this is respiratory rate at sleep. And so surprising, this is not difference between the groups. And actually, it's not significant different females at low altitude versus females at high altitude. And also in males, it was not different, the respiratory rate. What happened with the heart rate? No difference between the complete group, high versus low altitude. No significant difference when analyzed females, and neither for males. Saturation awake. The saturation was significant different for the groups from low altitude versus high altitude, but was a little bit higher awake. Females, also significant different, and also for males. Heart rate awake was not significant different for the whole group, and not different for females and males. The EPO was, we analyzed because to see the EPO stimulates the production of hemoglobin with transport the oxygen. So in the high altitude group was higher production of EPO, and it was significant different with between the groups. Was not significant different when we analyzed by gender. So this is going to La Quiaca, to the road, the Seven Colors, still in the same state in northwest of Argentina. So infants born at high altitude have lower levels of oxygen saturation compared with infants born at low altitude. However, no difference were found in respiratory rate and heart rate between the infants born at high versus the infants born at low altitude. Probably this is an adaptation from, these are native from here. The parents were native from the high altitude place, and also the parents were native from the low altitude place. And high altitude infants also have higher levels of EPO. So I think more data is needed for oxygen saturation and respiratory pattern from different altitude. This is just high altitude. We have probably more population in intermediate altitude than in high altitude worldwide. So thank you very much.
Very nice. I was wondering, will you be generating data similar to what you just showed, but for children who have acute respiratory illnesses, to see whether there is differences in other parameters or in clinical outcome?
You mean when the children are sick during disease?
With an acute respiratory illness, whether it be rhinovirus or RSV, do you see, let's say, greater they're already desaturated somewhat at higher altitude?
No, we didn't analyze this. It's just in healthy infants, and when we went there to test these infants, were during summertime because it's really cold during the winter. So I stayed like a week there during summertime, and we did all the tests during that week. And at 3 different points, but during summertime, we didn't see sick with acute respiratory disease infants.
If you're to continue this study, it would be nice to start looking at acute respiratory illnesses.
Yeah, sure.
Conrado, what is the criteria for admission to the hospital in children in La Quiaca? What do they use as a cutoff for oxygen saturation when they have to admit a kid with bronchiolitis? I mean, they don't.
I think it's mainly it's a clinical, the clinical symptoms, the clinical picture of the patient. With they decide. Actually, I'm because that was not when we were there, we didn't have contact with sick kids, so we didn't know. But probably they also use the saturation, but I don't know what level of saturation they are using to admit or to discharge the infant. But mainly, I think it's clinical. This is, I think now there are oximeters all over the world, but we need more data, I think.